So one of the first things we did with Sarah is have her fill out a Montreal Cognitive Assessment form. If you remember from her chief complaints, her number one chief complaint is impaired cognitive function, as well as low stamina and energy. Now, anytime you see a 35-year-old with significant cognitive function decline, we need to be a little bit concerned. So just to get an idea of where she's at, we had her fill out the cognitive assessment form, the Montreal Cognitive Assessment form. And you can see that her score is 26 out of 30. And if you remember, normal is above 26. So she's right on the border of meeting the criteria for mild cognitive impairment. Now, if you look at her score, you can see she forgot one of the names of the animals. She lost a point there. She had some difficulties subtracting from 7, so a little bit dyscalculia. She lost a point there. Then she lost 2 points in her memory index score. She couldn't remember all the different the recall of the word that she was given. So this is a bit of a concern. So during the examination, we want to really look for various things that can cause a 35-year-old to have mild cognitive impairment. The worst scenarios would be early Parkinson's disease. Early onset Parkinson's disease can happen with anyone between ages 21 to 50. So we're going to be very careful with her examination to see if she's got any rigidity, any stiffness, any loss of arm swing, any impairment of smelling, any peppermint coffee. Those are all early signs. We also want to consider the possibility that with her age, having significant cognitive function decline, does she have any kind of brain injury? A lot of people don't remember their brain injuries when they do a history, especially when they get focused on something like their Graves' disease or the thyroid, which she has. So remember, with traumatic brain injury, you can get chronic traumatic encephalopathy, and you have tauopathies, very similar to Alzheimer's disease. And then also the fact that she has, Graves' disease. Graves' disease is a combination of thyroid-stimulating antibodies as well as TPO antibodies. And we know that TPO antibodies can bind to the cerebellum, so we have to be concerned if she has any kind of cerebellar degenerative diseases. The cerebellum is very important in cognitive function. And then we also have the possibility that she may have autoimmunity. So we want to look for any kind of upper motor neuron signs, any signs of demyelination with the physical exam. And then if any of those things are there, whether it's demyelination or signs of a brain injury or any signs of early onset Parkinson's, then we have an idea what's causing her cognitive function to be declined. Now, there's also the possibility that these may all just be metabolic, that there's actually nothing wrong with her brain anatomy, and it just may be related to her metabolic patterns of maybe some thyroid fluctuations and imbalances, maybe even some thyroid resistance. She's on quite a bit of thyroid hormones. She has hypoglycemia. So it could be a combination of metabolic factors. So the exam is going to be very important for us to rule out early onset Parkinson's disease, potential markers for traumatic brain injury, any signs of demyelination, or any other types of autoimmunity. So these are all the key things to think about, just the fact that we have a 35-year-old with a Montreal Cognitive Assessment score of 26. So you can see with the handwriting evaluation that we see a normal response. Her font size doesn't change size when she goes from the first sentence to the last sentence. Now remember, with early onset Parkinson's disease, you can get some kind of rigidity and stiffness in the hands, and the font can get smaller as you get to the 7th or 8th sentence, and hers are normal. And then also with cerebellar disease and injury, which she may have potentials for because of TPO antibodies, you can see the font size getting bigger, like a macrographia, as they lose the ability to calibrate smooth muscles with supination, pronation, other functions. Usually handwriting font increases. And then we checked the Archimedes circles, and there's no signs of any type of tremor there. So these are all good signs that we don't have any initial findings of these red flags that we're concerned about from the Montreal Cognitive Assessment form. So our seated blood pressure, after sitting in that position for 3 minutes and having in a resting state, is 100/67. So we'd like to see, obviously, blood pressure in the 120/80 range. She's on the lower side. Now you have to remember she's underweight. Remember, body fat helps release adipokines, and adipokines have modulating effects on neuroendocrine immune function. And when you have low blood pressure like this, with a history of reduced energy and stamina, you have to consider the fact that there's lack of perfusion and blood flow going to the brain. That could be one of the reasons why her cognitive impairments may be there. So as we look to find physiological mechanisms that may be impacting her chief complaint, which is cognitive impairment, seeing blood pressure in the 167 in combination with her symptoms of hypoglycemia already means that her brain may not be getting enough oxygen. And remember, perfusion from blood pressure is also necessary to carry hormones and other nutrients necessary for mitochondrial function. So that, with low blood sugar, being underweight, may all be contributing to her cognitive impairment. Now, when she stands up, her blood pressure does go up 121/70, which is a really good sign, which means that she has some integrity in her autonomic and catecholamine systems to regulate her blood pressure. And we don't see any history of patterns of orthostatic hypotension and any dizziness when she stands up, which are all good signs. So her pulse oximeter, perfusion index, and heart rate are within normal ranges. Her perfusion index is 0.63. It's not the best, but it's still okay. We like to see it at least 0.8 or higher, so it's a little bit low, but she has low blood pressure. Her pulse rate is 77, which is fine, and her SpO2 is 99% oxygen. So this makes us less concerned about any kind of pulmonary-related issues, any cardiovascular-related issues that may be impacting her overall health. So the Accutane took care of any of your skin reactions?
Oh yeah, all my acne.
You were getting any redness? You have a little bit of redness.
Tiny bit, yeah.
Up there. Is that more than usual?
Mm-mm.
Okay.
It's the same. I'm only getting like tiny little bits of acne around here.
Yeah.
I don't know if that's the food, relative to food.
So when I look around the skin around her arms and face, you can see that she has a little bit of cystic acne around her lips. And cystic acne is really an inflammatory form of acne that's caused by inflammation. And then she's got a little bit of atopic dermatitis or eczema around her forehead, upper eye area. And I used a magnifying glass to look at these things. So it's not as clear in the camera, but it was much more clear in person. Now, if you are evaluating the skin into your patients, it's always great to have a little magnifying glass. You can really see things a lot better. So what we can see with her is that she's got some inflammatory reactions of cystic acne and eczema, which is a reflection of her immune system, right? The skin is a great window of what's happening with the immune system, and so we see some systemic inflammatory responses in her skin. Nice and healthy looking. Refill time is pretty good. Examination of her nail beds, capillary refill time, and skin turgor test are all within normal findings. Her nail beds are a little bit paler, but they're still within normal limits. That could just be due to her low perfusion index, but they're still within normal levels of color we like to see. Capillary refill time's fine, and her skin turgor test is fine, which means she's not dehydrated. So those are all great findings. All the way down. Okay, the other side. Anytime you have someone with a chief complaint of low stamina energy, you definitely want to look for signs of anemia. So when we evaluate her inner eyelids, we're looking for that nice pink color, which she does have. People that have anemia sometimes have a very pallor inner eyelid, but with her everything is normal. Just touch your fingertips. Yeah, it's a little cold, but nothing drastic. Let's try your legs. You can just let your arms relax. Freezing. Big change.
I knew I should have painted my toes.
It's like a 17-degree difference.
Wow.
Really?
Wow.
Can you see? Like we're up here.
See, what's so strange is that I get so physically uncomfortable with like regulating my body temperature.
Whoa! It's bad circulation. Okay. And then you're blue here.
That's funny, not funny.
I
It's
know.
pale and white. Should be pink.
Should be pink like my
Look
hands?
at that. See how nice that looks? It's like zombie nails. So her peripheral temperature and circulation evaluation identifies a few things. First of all, there's definitely some poor circulation, poor blood flow, and even potential vasomotor imbalances. And vasomotor imbalances can sometimes occur with people that have thyroid dysfunction that's not being treated, or in her case, it just may be the fact that she's taking a lot of thyroid hormone. She's taking not only T4 but T3, and at very high levels. And she could have a combination of thyroid resistance having an impact on that. So there's probably some influence of her thyroid medication, her underlying thyroid condition, and her lower blood pressure and perfusion index issues all potentially playing a role. Now you can see in the upper extremity it wasn't as bad. It was only a 10-degree difference, which it was within the normal borderline areas. And then if you look in the lower extremity, you can see that her blood pressure, her surface temperature goes from like 89 to almost 69, 17 to 20 degree difference depending on when we test. And then if you look at her nail beds, you can see that cyanosis in her toenails, and just touching her feet, it was just like they were frozen. So we definitely see some issues here related to circulation and blood flow. Now, circulation and blood flow could have a significant impact on cognitive function, because you have to, get proper, regular, healthy blood flow to the brain. So just like her toes are freezing and cold and have some cyanosis, those types of mechanisms can also take place in the brain. The brain is also very peripheral, just like the feet, but it's also vertical. So it's very prone to having, hypoxia-related events that may be impacting her general brain function as well. Now, I think her vasomotor tone is going to be a combination of trying to get her thyroid hormones balanced, trying to get her blood sugar in balance, trying to get her perfusion index improved, trying to get her hypoglycemia, adrenal function all under control. So it's going to take a little bit of time, but it's definitely something to not ignore. Take some deep breaths in and out, and then in, out, and then just take a deep breath in and out every time you feel the sign. Deep breath, deep in. There you go. Deep breath in and out. Again. Okay. Deep breath in. Out.
Making me dizzy.
Just take your time. Take a deeper breath in. Again. Again. Deep breath in. Okay, I'm gonna check your chest. Deep breath in. Hold it out. Okay, with auscultation, I go through and first auscultate her thyroid gland. Anyone with Graves' disease or autoimmune thyroid, you definitely want to make sure that they're in a hyper state when you're doing an examination. When people have hyperactivity of the thyroid gland, you can actually hear blood flow over the thyroid. Normally, you won't hear anything at all. Then I just listen to her carotid arteries, make sure everything's okay there. Then her heart and lungs and everything is normal. There's no abnormal heart sounds. There's no abnormal lung sounds. She has healthy lung expansion. I checked her chest expansion. Everything is within normal function. Now let me get, John, can you get a look at this here? Your skin is really red.
Mm-hmm.
We can kind of put our finger impressions on it. So we're going to check your histamine levels.
Okay.
So when we examine her skin, we can see that she has some skin blanching and she has some xerodermia or dry skin. Now, the blanching may be related to vasomotor tone imbalances, may be related to high histamines, and may be related to liver disease. Now, liver disease is unlikely because with her past medical history in her labs, there was no indications that there's any problems there. Her transaminase enzymes, her laboratory markers that would be associated with liver disease, like albumin, globulin, SGOT, SGPT, GGTP, they're all within normal reference ranges. And it's possible that she may have some vasomotor tone issues just because she's trying to balance out her thyroid hormones and she's taking a lot. And as you start to reduce your dosage, which she's trying to do with her endocrinologist, you could have periods of time where you have too much thyroid hormones, you back off, and then you get a little bit of thyroid resistance with a period of time where there's not enough thyroid hormone receptors, and then that can throw off the amount of thyroid hormones that your tissues need, so you can get some vasomotor tone issues, which is still possible with her, and that can be a reason why she's having some skin blanching as well. Tight muscles.
Yeah. I don't know if I was sitting properly at the desk yesterday. I know exactly what he's going to say.
You do have lymph nodes that are swollen.
Yeah?
Yeah. You feel that?
Yeah. It always hurts back there.
Okay. Let me go in here.
I always have tension in there.
Yep, you got swollen lymph nodes.
So what do we do about that?
Well, we know your immune system is involved. Relax. Here.
I'm always feeling pressure in that area.
Yeah. You feel this? Yeah.
Mm-hmm.
You feel that? Yeah.
Yeah.
Right there. Oh. Yep, right there.
Mm-hmm.
Yeah, those are swollen lymph nodes. Okay, let me palpate your thyroid. Bring your head back just so I can get what's there, just stick out a little bit. I'll just inspect it there. Okay. So palpation of the lymph nodes shows enlarged occipital lymph nodes, submental lymph nodes, and submandibular lymph nodes. So that'll just know that she's got some type of, immune activation. Whether she's dealing with a recent virus or chronic virus, it's not clear just from the physical examination. Now, her previous lab work didn't really show any significant patterns where we would be too concerned about her immune system, other than she has an autoimmune disease. Now, remember that she does have Graves' disease and had radioactive iodine, so part of her thyroid gland is destroyed. Now remember, when you do radioactive iodine, you don't have your entire thyroid gland destroyed. You just have different parts of it destroyed to calm down the hyperactive response. So you can still feel swelling or any kind of abnormalities with some people, but her thyroid exam was totally normal, and we just see those indications of some lymph node swelling with her palpation around her neck. Okay. Does this irritate your skin? Is that okay? Do you still feel?
I still feel it after, yeah.
You still feel it?
Mm-hmm.
Because you can still see the lines.
Mm-hmm.
You can see those lines there.
What does that mean?
You could have a lot of circulating histamine. There's some things impacting your vasomotor tone going to your skin. Could be a lot of things.
Mm-hmm.
But it's like, this is called dermatographia.
Okay.
Meaning dermatic skin, graphia, right?
Right.
So like if you write a letter.
Yeah, you can still see it after.
Yeah. Well, the O was easier.
Mm-hmm.
There's an O.
Mm-hmm.
You can see these lines here. Okay. Let's see your hands here.
Would there be any correlation between that and difficulty with getting a suntan? And I'm not saying that in vain. I'm just asking because I used to darken very
Yeah, I remember
quickly.
reading that. That could just be a prostaglandin imbalance too, but I'm not sure what that is specifically related to. So with the abdominal reflex, you just stroke the skin and you should see the belly button move to the side you're stroking in, and hers were normal on both sides. As far as the motor response is concerned, and I'm going through and just checking for any signs of upper motor neuron disease, since there's always the possibility for demyelination with anyone that has any type of autoimmune disease like Graves'. Many people have, as you know, many other autoantibodies to other tissues, and the brain could be part of it, and with her cognitive decline, it's something to consider. Now, you can also see that when we stroke her skin, she's got those dermatographia presentations, meaning you can see the handwriting, you can see whatever you're drawing on the skin, and it lasts for a period of time. So that could also, again, be vasomotor tone issues, or it could be related to high histamines. So either one of those two are possible. So as she figures out how to balance her thyroid hormones, and obviously she's taking way too much in her body composition, and she's underweight, and she's not able to gain any kind of weight, so she's more than likely being overprescribed. There's a desperation for her to function and feel better, but it may be expressing itself with these vasomotor tone imbalances. But we also want to take a look at circulating histamines whenever we see dermatographia. Now, histamine-related dermatographia sometimes just causes itching of the skin, especially when you stroke the skin. She doesn't have that, but she does have a little bit pattern of hyperalgesia where she continues to feel that sensation. So there's definitely things that are depolarizing her nociceptors where she still has that perception for a period of time. Now, excess thyroid hormones could be a potential factor that could be doing that, but it could also be histamine. Histamine can also depolarize receptors. And the last part of the exam here, she asked about the fact she can't get tan. And you have to remember that the essential fatty acids have really significant clinical expressions on the skin. And when people are low in essential fatty acids, they get sunburned very, very easily. So essential fatty acids provide some protection from UV with the skin. So it's more than likely she doesn't have enough essential fatty acids. It's pretty clear from her diet she's just not eating enough fats and healthy fats that would contain those essential fatty acids. And usually people that are essential fatty acids will have the dry skin like she has, and they'll get sunburned really, really quickly because they don't have that essential nutrient to provide a bilayer for her skin and or offer some degree of protection. So during the abdominal exam, abdominal auscultation was normal. She had really nice bowel sounds in all quadrants. Palpation was normal. There was no signs of tenderness or inflammation anywhere. And with her skin blanching, especially over the liver, you want to see if there's any tenderness or swelling, and they were fine. And then percussion sounds were okay. So there doesn't seem to be any abnormal enlargements or sensitive areas of her abdomen, and her bowel sounds are normal. This way here.
Oh, sorry, I think I caught my hair. No.
Okay, with the decline test, you can see me put the patient in an extension rotation position. That's just to stretch out those vertebral arteries and see if there's any symptoms. And usually if you see nystagmus or any kind of blacking out, lightheadedness, then you'd be concerned about the vertebral arteries. But sometimes when people have vestibular-related issues, you don't see the nystagmus, you don't see those patterns, and you can definitely trigger them without the head and extension rotation, just with movements and other things. So with her, everything was intact and no concern for mechanisms that may be involved with cerebellar patterns. Sometimes when people have cerebellar autoimmune reactions or gluten-ataxia patterns because of history of Graves' disease, you can see some abnormal findings with this test, but she's fine.
Cocoa?
That's your name?
Coffee?
Okay. Other side.
Coffee.
Okay.
Mint?
Okay. Other side.
Mint or peppermint?
They're both right answers. Shake it a little bit. Can you smell it?
Yeah, I can smell it, but
It's hard to identify.
It's just hard to identify. I want to be like, oh, it's some Italian seasoning or...
Okay.
I'm...
Anise.
It's what?
Anise.
Oh, I would not know anise. Here.
Right there. Okay, try the other side.
Okay. Now.
Okay. So the olfactory exam is really important. If you remember, the Montreal Cognitive Assessment Form was borderline at 26, and a 35-year-old with a chief complaint of cognitive decline, you really want to make sure that there's no indications for early Parkinson's disease. And the three scents that have been shown to first be diminished in Parkinson's disease is coffee, anise, and peppermint. Now, she was able to recognize everything. Obviously, anise she wasn't able to recognize. Most people that aren't cooks may have a hard time with anise, but she did notice like an Italian smell on was equal from right to left, so we're going to consider that normal. The peanut butter sniff test is just a test that can be used to identify some early patterns of hippocampal inefficiency, which can take place with early Alzheimer's or dementia patterns. So there's direct olfactory projections into the hippocampus from smell, and if there's a discrepancy one side or the other, a few studies have shown that could be an early finding of early dementia. Now with her, all her olfactory exam findings were normal. Tastes like?
Salt.
Perfect. If that is?
That's sweet.
Yep. Here I'm just testing her gustatory evaluation. She can perceive scents. It's just part of a cortical bulbar examination because we're always concerned about demyelination with a history such as hers. Again, all the way over there. Perfect. There we go. So you can see me doing the corneal reflex. I just gently touch her cornea with a napkin and look for that blink response. So if you remember, the sensory portion of the trigeminal V1 is where it's going to perceive that napkin, and then there's going to be a reflex with facial motor 7 to cause the eye muscles to constrict. And with her, these are normal. So these are just looking for any patterns of demyelination that is involved with mid to lower pontine regions of the brainstem. if you can feel this.
Mm-hmm.
Okay, point to where this is. Okay, you're right.
Mm-hmm. Mm-hmm. Mm-hmm.
Okay.
Yep. Yep. Yep.
Same. That's right.
Yeah. Yeah. Yep.
Do you still feel them?
Yes.
Okay. Tell me
On
when they
my
go away.
hands.
I know. Tell me when they go away. That's your high histamine.
Okay.
We have to check you for IgE-related reactions to food and chemicals.
Okay. I feel a little bit here, but it was mostly in my hands.
You know you can draw on your skin.
Mm-hmm.
Do you ever see that go away? Do you notice a difference, or do you ever see it get worse?
Never see it get worse, but I've had that. Like, different periods of my life, I had it greater than others. Like, my friends and I would goof off. We'd do, like, tic-tac-toe.
How about your skin itching?
So, that's the other thing I forgot to mention. My nose will itch like crazy. And I've literally had sandpaper to itch my nose and it's happened like after I'll eat certain foods. I don't know if it's like the residue of the oil, and I make sure I wash my hands and wash my nose because it itches so badly, and sometimes it still doesn't go away.
Which foods?
I haven't pinpointed a food.
Okay, well, you need to start pinpointing.
Because it is like out of control itchy, and it's just my nose.
It can be anywhere, but that's okay. You do notice reactions to your skin when you do eat, for example, a severe reaction, right? Like you're saying pepper flakes. Right?
Yeah.
Is there anything else that you notice a skin reaction with?
Just anything in the pepper category.
In the pepper category.
Yeah.
That's it?
Mm.
Is there any environmental, airborne plants or
Not
flowers?
that I
anything
know
that you're aware
of. I'm just really careful with like products that I use.
Okay. Do you notice any difference between East Coast and West Coast since you've been traveling this week?
I think it's too soon to tell.
You can't tell.
Mm-mm.
How many days have you been here now?
Just
West Coast?
since Monday night.
Monday night. So it's the third day. Okay.
Just want to raise that your skin, the soaps. Did you just say it?
Yeah, it was in my file.
Yeah, I read that.
Yeah.
Just tell me about it more.
So I'm allergic to antibacterial sodium lauryl sulfate, but it's just been on my hands and my feet.
Yeah.
So I don't use them. I cut them out since high school, and I just use
And alcohol as well.
and alcohol wipes. Like I can't touch like my hands. I always get a reaction on my hands and my feet. If I touch them on my hands, I can get a reaction on my feet.
Okay. So if I
Or
were
both.
So if I were just to do this to you, you feel that?
Mm-hmm.
Do you still feel it?
Mm-hmm.
Tell me when it goes away. Still feel it? Because that's abnormal.
So I used to think I was just overly sensitive, like
Right.
physically
And I remember you
sensitive.
wrote like on the case review when you were typing, and it was small letters and heavier keys and all that.
Yeah.
You've got some histamine related stuff happening.
So how does that get addressed?
Hmm?
I still feel it.
That should go away. Every now
Yeah,
and then
that
check.
should go away. Yeah, like
So during this part of the exam, you can see that her light touch is normal. She can perceive the tissue throughout different areas of her skin, but she has a exaggerated response to pinprick perception, and she has it all throughout her body. And usually, if you have like increased perception of nociception, you can have this pinprick response. And if it's only on one limb, like on one side, you're more likely thinking of a head injury on the contralateral parietal lobe that can cause that. But when it's like all the limbs and all throughout the body, then it's not a brain injury. It's not something related to a specific region of the brain, but it's really metabolic, right? And in this case, we see this presentation all throughout her body, both limbs, and even her feet and other areas. You can see in the exam she'll have this increased sensitivity. So this is basically hyperalgesia, but she doesn't have a chronic pain syndrome. She just has really, really sensitive skin. And it's possible that this could be histamine. Now you saw I was asking her questions about have you noticed any changes recently or in the past? And she says, too quick to tell. Usually with IgE reactions, you get that mast cell histamine response. It's pretty immediate. She wasn't able to identify those patterns. IgG responses don't typically cause that mast cell IgE, the mast cell histamine response like this. So if it's not allergy or histamine, we'll have to wait for the lab test to come back. Then it could just be from vasomotor tone imbalances. And more than anything, it's probably her thyroid hormone excess, and she's trying to back off, and those receptor sites are trying to catch up. They could be playing some significant role with her vascular function and blood flow to her skin that can have an impact there. Now, thyroid hormones themselves also depolarize nociceptors, and if there's a little bit too much of them in the system, which appears to be happening with her with some degree of thyroid resistance. So let me explain that. When someone has excess thyroid hormones, like an acute thyroiditis response or something, then they'll get anxiety, nervousness, and trembling, and all the signs of hyperthyroidism. But if someone is slowly increasing their thyroid hormone dosage over a period of time, they don't tend to get those hyperthyroid symptoms, but it causes a person to not be able to gain any muscle mass, not gain any weight, and have vasomotor tone issues. So it's very likely that may be happening with her. Tell me if you can feel that vibrate.
Mm-hmm.
Okay. And
Mm-hmm. Mm-hmm.
does that go away?
Yeah.
Yeah. See, it's different than pinprick. Okay. Tell me you feel that. Just let your foot relax.
Mm-hmm.
I feel the same from.
Yep.
And
Hi. Yes.
same.
Yep.
What do you notice here?
It's just.
Shocked you.
It just feels like it's right on the bone. That's why.
Yeah. And as soon as you feel that's on your skin, you're gonna say now. Okay.
Now. 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 Now.
These are your
No.
histamine responses.
No.
Are you okay?
Yeah.
Your whole body
Super
is.
ticklish.
I'm just overly. No. I'm just too ticklish. Now. 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 No.
You okay?
Yeah.
You're flushing a little.
Because I'm ticklish. No. No. No.
So tickle is just nociception. Nociception is pain. Histamine depolarizes nociceptors, so it makes them fire much easier. It's just borderline pain you're feeling. Okay, with vibration perception and monofilament testing, we can see she's got that increased sensitivity, that hyperalgesia type response once again. Now, one of the most significant findings from that part of the exam was when we were doing the monofilament test, she started flushing all throughout her limbs. You can see that red color develop. That is a strong indication that it's more likely vasomotor tone than it is histamine, but we still have to rule out elevated histamines by running a blood test and seeing if she has any IgE reactions that may be contributing to some of that. Tell me explain what that is. Feel
Oh, it's paperclip.
Okay. And this one here. Oh, yeah, just a
Battery. Sorry.
You can feel it though.
Yeah, I can feel it though. Yeah, battery.
Tell me what letter this is. It's not really drawing on. Just pretend.
T or X?
Okay.
Oh.
Your pointer finger is number 1.
Mm-hmm.
This is number 2.
Mm-hmm.
This is number 3.
Mm-hmm.
And that's number 4.
Okay.
Okay, close your eyes. Tell me what number I'm touching.
1. 2.
Don't move your hands at all. Which one on the left?
3.
Which one on the right?
3.
Okay. So when we check stereognosis, graphesthesia, and extinction, we can see that everything's intact. So this lets us know that her parietal lobe is really, really healthy, and more than likely that her sensory sensitivities are unrelated to anything happening at the parietal lobe function. That it's most likely related to those sensory nociceptors being closer to the threshold and not associated with brain dysfunction or brain injury. There's 1. That's 2. Which one's colder?
1.
This is 1. That's 2. It's colder.
1.
Which one's colder?
Same.
Same.
Colder. 1 was colder.
And this one's a hard time for you.
Yeah, they feel the same.
Open and look. Can't tell.
Now I can actually feel that one being a little bit colder.
Now you can close your eyes.
Mm-hmm.
This is just really your circulation that's causing that.
Cold, warm. Cold, warm. I can slightly feel it colder on number 1.
It's harder.
Slightly, yeah.
Yeah, different here
Mm-hmm.
than over here.
Completely,
right?
yeah.
Okay, let's try your feet. Can you feel that?
Mm-hmm. Cold, warm. Cold, warm, but it's slightly different.
Harder.
Cold, warm. I can tell. I can't really tell.
Okay. So evaluation of temperature perception with her is a little bit impaired in the distal areas, and that's just a sign of poor vascular dynamics. As we know with her, she's got some vasomotor issues, she's got some poor circulation issues, and whenever you see that temperature discrimination is much, much more difficult in the very, very tips of the fingertips or the tips of the toes, then you know it's really more of a vascular issue than it is a neurological issue. Now, when you saw me examine her feet, you can see that the color in her feet have returned. They're much, much more red. Her nail beds that were cyanotic are now just pallor, just white. So, you know, you can really see these vasomotor changes happening just within a very short period of time during the examination. And more likely, these are associated with her thyroid hormones more than anything else based on her history. Just look up here. Just gonna check a couple of reflexes. Look up here, try not to blink. There you go.
Let me just part my hair out of my...
There you go.
There we go. That's a little helpful.
Okay. I'm just gonna check your details. Okay, let's do things. Relax.
Should I
It's a lot
explore?
of jumpy. Okay, it's a little jumpy there.
Crap. Oh,
That's yours, sorry. Ridiculous. Okay, those are good. Let's check a couple other things here. Squeeze. Hands over here. So during this part of the exam, I'm just looking for any patterns of upper motor neuron disease by looking at pathological reflexes and checking her deep tendon reflexes. So palmar stroking is totally normal. The rooting reflex is totally normal. The glabellar reflex is a little bit off, but it's within what you see with normal function. So glabellar reflex, you ask a person to not blink, and then you tap in between your eyes. Now, normally you would blink if someone taps you, but when they tell you not to blink, you should be able to suppress that blinking response. And she hasn't completely suppressed. She doesn't have complete suppression of it, but she does have the ability to suppress it. What's normal with Parkinsonian disease, people lose this glabellar reflex, but with her, it's still within normal limits. She can't suppress it. It's just she still has a little bit of blinking. And then the Clonus test is normal. Babinski's normal. Gordon reflex, just squeezing your calf, Chalmers sign, and the upper extremities of the fingers. Those are all intact. So we don't see any signs of upper motor neuron lesion, or we're concerned about that with any kind of demyelination. If you remember, since she has significant cognitive decline and she has borderline mild cognitive impairment on a Montreal assessment form with a history of Graves, we're always concerned about autoimmune in other regions. Any kind of demyelination anywhere from areas of the frontal motor strip all the way down to the pyramidal tracts into the anterior horn of the spinal cord, if there's any injury, we would see some of these pathological reflexes abnormal. And with her, they're all intact, so it doesn't suggest that there's any kind of demyelination in the motor system from these findings. Transfer it out. Play the piano as fast as you can. Okay, foot. Fast as you can. Left side.
Okay, I'm gonna try this.
The two of them together. Together at the same time. Okay, left side.
I don't know why I can't.
And right
Should I
side?
do it out this way and do it this way?
No. And right side.
I can't go any
Okay,
faster.
cool. Remember, just do the right side first. And then the other side. Pretty good. Same time. Faster. Faster. Very good. Okay. So here we're checking her rapid motor testing with her fingers and hands, and we're looking for two things. First of all, we're looking for any type of slowness, any hypokinesia. And one of the things we're constantly trying to rule out is early onset Parkinsonian disease. And one of the first things people lose with Parkinson's disease is their motor speed. So with her, we see great motor speed. And then the other thing we're looking for is to see if her frontal lobe, her prefrontal areas, her premotor regions are involved. And they're involved with planning movement. And people that have dysfunction there get dyspraxia. They can't really figure out how to do finger to thumb very well, or they get frozen when they try to do it, or they get frustrated when they try to do it. But with her, everything's intact. So we're not seeing any indications of any premotor planning dyspraxia, and we're not seeing any signs of hypokinesia associated with early onset Parkinson's disease. So that's great. The other side. Try that again. Try to get right on your kneecap and then straight down your foot. Eyes closed.
Oh, like
Yeah,
right.
try to get with eyes closed.
With eyes closed?
Mm-hmm.
Oh, crap.
Other side. Great. Okay. So with heel to shin testing, we're checking for cerebellar integrity. As she targets her kneecap and goes straight down her leg, we want to see if we see any overshooting or undershooting, or hypo or hypermetric responses, over undershooting. And she doesn't have any. And then we look to see if there's any kind of tremor when she does that, and she doesn't have any. You can see her foot kind of move as she gets close down her pants, but she's going down in a straight line, and that's not a tremor. It's just her feet rubbing against her pants there. So these are intact, and just helps us rule out any kind of cerebellar dysfunction, which is common to occur with autoimmune thyroids because of that TPO cross-reactivity. Your forehead. I'm going to close your eyes tight. Don't let me open.
Don't open.
Don't let me open them. Perfect. Okay, now open your eyes. Pull out your cheek.
Pull out.
Okay. Push your tongue against your cheek. By the one side. Other side. Testing facial muscles and the tongue, the hypoglossal nerve functions are all within normal function. It lets us know that the anterior regions of her mid and lower brainstem are intact. Look straight in. You can see the light hits right in the middle of those pupils. Perfect. Okay. Look up here. So in this part of the exam, looking at the pupil light reflex. So I shine a light directly in the center of her face, and I want to see that light hit her pupils exactly in the same region, and it does with her. Now remember, she has a history of Graves', and when people have Graves' disease, there is the possibility that her ocular muscles, her eye muscles, get enlarged. So there's a phenomenon with Graves' disease where there's a target protein that impacts the cartilage in the tendons of the eye muscles, and when that gets injured, it causes swelling, and there's enlargement of those eye muscles, and then the eyes can sometimes bulge out, that proptosis pattern. And when that occurs, you'll see these abnormal pupil light reflexes because your eyes will be misaligned. And then also, you can also see double vision with pursuits, which we'll check in a second here. And then cover-uncover testing just to see if she's got any kind of strabismus or any eye deviations are important. And with her, everything was intact. So she doesn't seem to have any issues with her Graves' disease impacting her eye muscle, and there's no misalignment of her eyes. Okay, perfect. And go back and forth, targeting these two fingers with your eyes.
When you say targeting,
Boom, 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 boom.
oh, just back and forth?
Mm-hmm. Okay, great. We'll have you look straight at the tape, look at the red stripes in front of you,
Mm-hmm.
and just keep your eyes on the red. Keep your eyes on the red. In this part of the exam, I'm just checking her eye muscle function by checking cardinal fields of gaze, which are also visual pursuits, targeting back and forth saccades vertically and horizontally, and then that red and white tape, the optokinetic reflex. And everything looks healthy and intact there. Now with cardinal fields of gaze, you can see that she's moving her eyes smoothly without any kind of breakdowns when we do it. She doesn't have any double vision. Sometimes you only see expressions of an enlarged eye muscle when there's double vision at the end of target. Now when I was doing the cardinal fields of gaze and going down to her left, it looks like she had a little bit of catch-up saccades, meaning that her eye was tracking, then lost, and then tracking it. And that was just because she wasn't paying attention to where my finger was. It wasn't really due to pathology. And then her saccades targeting fingers should be nice and equal in speed on both sides and hit the target without the eyes going over the target and catching back or missing the target and then targeting again with their eyes. And then our optokinetic reflexes should be equal between right and left and have that type of bouncing type of movement, which checks for integrity of the right parietal insular vestibular cortex and some brainstem reflexes associated with the third and sixth cranial nerves. So it's just a very good evaluation of different regions of her brainstem and different regions of her brain, which are all intact. And you're going to keep your eyes right in that spot. In this part of the exam, I'm checking her vestibular ocular reflexes and doing a Helmegi maneuver, or like a head thrust maneuver. And these are just looking at the integrity of those vestibular pathways in the brainstem and cerebellar function. Remember, we're always concerned with anyone with Graves' disease, with significant cognitive decline, if they have any autoimmunity involving the cerebellum. It's very common with the gluten sensitivity component. It's also common with the TPU antibody response. Now, when you turn someone's head to the left, the eye should move to the right. When you turn someone's head to the right, the eye should move to the left, and it should be smooth, and hers are. And then once you have the head in one position, if you bring it back quickly, the eye should come back to center without bouncing back and forth. And if they do bounce back and forth, then you're worried about the integrity and health of their cerebellum. Now, with her, everything was normal. So here I'm just checking the direct and indirect pupil responses, and they are working perfect, and there's no signs of a pupillary afferent defect. So we know that the upper regions of her midbrain and her autonomic functions are intact. Open your mouth. You stick your tongue out. Well, that is definitely scalloped. Show that. Say ah.
Ah.
Sorry. Open it.
Ah.
Relax. And again.
Ah.
Okay, just relax and check your gag reflex.
Ah.
It's really a good gag reflex.
Too strong.
Okay. You're tearing a little bit from that. That's okay. Nice and healthy brainstem response. Your saliva production is really good. Lots of saliva there. Stick your tongue there. Lots of saliva. Nice. So with the examination of the tongue, you can see that her tongue is swollen, it's scalloped. The scalloping happens when the inflamed, swollen tongue pushes against the teeth and you get those little ridges on the inside, that scallop presentation. So we suspect that she may still have some underlying intestinal inflammatory issues, even though she had some positive responses in her history with supporting her leaky gut. There's still some things happening, most likely, in her gut. And when we look at her mouth and palate, and her saliva production, everything is great. And these are really great reflections of parasympathetic function. So we can see nice wet mouth, which means her salivary gland, her parasympathetic function is great. Her gag reflexes are working great. Her palate moves great. So her vagal function and parasympathetic responses are nice and healthy. Yeah, that's actually nice. You can see the light there. Mm-hmm. Let's try the other side. There we go. Nice light in there. Okay. You can see here that her sinuses illuminate really well. There's no signs of sinus congestion occurring with her. And then her nasal septum evaluation was normal. There was no deviations that occurred. Just look at one spot and keep her right there. You getting the floaters?
Yeah.
Okay. So fundoscopy using a panoptic evaluation showed basically a healthy retina, normal optic cup, normal optic disc, healthy arteries and veins, normal fovea and macula, and no signs of any pathology or increased blood pressure or any type of disease involving her retina or her structures within that region. Let's take you back. Come on back. All the way back. All the way back. All the way back. Keep your eyes open. Any dizziness or something?
No.
Okay, come on up. All the way back. Great. The Dix-Hallpike maneuver was done to see if there's any indications of benign paroxysmal positional vertigo as just a quick screen. And when we put her in these positions, we don't see any nystagmus or any symptoms of dizziness, which means her test is normal. Come on back. Just keep doing that a couple times. This time when you come back, as you walk, do every other letter of the alphabet. A, C. Okay.
Okay.
Go ahead, out loud.
A, C, E, G, I, K, N, O,
Perfect.
Q.
Okay, great. You can see Sarah's gait is very good. She has normal arm swings all throughout gait. She doesn't have any signs of instability. She doesn't cross her feet. She's not trying to find her balance. Even when we have her double task, she doesn't slow down. Her balance doesn't get worse. And she seems to have really high motor function associated with ambulation. Put one foot in front of the other, eyes open. Couldn't make yourself stable.
Mm-hmm.
Close your eyes.
I feel the trumpets.
That's pretty good. It's not too bad.
Okay.
Put your foot back, eyes open.
Mm-hmm.
Put your foot, left foot forward.
Mm-hmm.
Close your eyes. Your eyes are already closed. That's pretty good. Pretty good. Stand on your right foot. Close your eyes. Great. Stand on your left foot.
I start to feel it tremble. I used to be able to do this so much better.
Okay, great. Now come on back. I want you to keep your eyes open.
Okay.
You go heel toe all the way across the room without lifting your arms. Pretend you're on a balance board walking. Okay, eyes open.
So I can't look down?
No. Okay, and then close your eyes. Okay, that's great. Come on back. Stay right here. Keep your eyes closed. I'm going to give you a little pull. You're going to try to keep your balance, okay?
Mm-hmm.
And one more time. Eyes closed.
Mm-hmm.
So with the stability test, we can see that Sarah has really good balance. And her Romberg's test is normal, her tandem Romberg is normal, and even her tandem walking with eyes open and eyes closed are all normal. So this, once again, rules out any type of potential cerebellar or vestibular types of dysfunctions or any kind of neuropathies impacting the bottom of her feet. And for the most part, we see a really healthy cerebellar vestibular system with her, and overall pretty healthy brain when it comes to modulating stability and ambulation. Now at the end of the test, you can see that I went through and did what's called a pull test. The pull test, as you know, your patient stands and you give them a little tug and you want to see if they can catch themselves with less than 3 steps. And with early Parkinsonian disease, people will have more than 3 steps. They'll lose their postural reflexes and just sometimes even fall or take many, many steps once you give them a little pull. And with her, it was normal. Fast you can. There you go. Fast, fast, fast. Fast, 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 fast.
My arms are actually getting tired.
Okay.
Like my actual
Neural
arm.
energy.
Yeah.
Elbows in.
Huh?
Elbows in. And then do the same thing. Okay, hands out. Play the fingertip, play the piano as fast as you can. Like this. That's great. Tip of finger to tip of nose. Perfect. Okay, great. And go back and forth. And I'm going to move my finger.
Okay.
I'm just going to keep targeting. Other side. Left hand.
Mm-hmm.
Perfect. So motor coordination testing with rapid supination, pronation, piano playing, finger to nose, finger to examiner's finger, were all intact. As a matter of fact, you can see really smooth, rapid functions with these responses. Supination and pronation, sometimes when you have abnormal calibration with the cerebellum, you see one side with that dysdiadokinesia. She didn't have that. Piano playing, you're looking for speed. You're looking for any type of issues with planning one finger versus us as far as motor movements. Those were intact. Then with finger to nose, you're just making sure that they can target. And this is a reflection of parietal lobe assessment. She misses it once with one of her fingers, but then she's able to do it perfect from that point on. And finger to examiner's finger is normal. So she can target very well, and there's no signs of tremor, which all indicate that her brain is healthy in those cerebellar, frontal, basic ganglionic motor loops. Sorry. Okay?
Yeah.
Great. Perfect. Right. So the otoscopic examination is normal. Her eardrums are nice and healthy. There's no signs of inflammation or swelling. I use a pneumatic otoscope where I puff a little bit of air into her to see her eardrum move, and it does move really well. But also if there's any type of holes or tears in the eardrum, you'll see someone get dizzy, and she didn't have any of those patterns. And then when checked her tympanometry examination, you can see that her eardrum has those really nice healthy movements and no signs of infection, swelling, or any injury to her inner ear.
Mm-hmm.
Put this on top of your head. Tell me if the sounds are equal, left to right.
Mm-hmm.
Okay, which one's louder? Here's 1, here's 2.
2 is louder. Sorry, 1 was louder.
There's 1, there's 2.
Yeah, 1 for sure.
That's 1, that's 2.
1 for sure.
So checking for gross hearing using the Weber's and Rhine's test with the tuning fork were all intact. So her hearing is nice and healthy. We're going to just look at the pupils first. Okay, so we're looking at your pupils. So in darkness, they're dilated. We turn the lights on. And we get a nice constriction. Perfect. Turn the lights on. And they dilate. Great. You're going to bring this towards your nose, and we're going to look at your eyes. Go ahead and bring it towards your nose.
Do I actually move my finger, or I make my
bring
eyes
your finger
move?
towards your nose. Keep going. There we go. Convergently accommodate. Perfect. Come on out. In this part of the test, I'm using infrared goggles to just really look at her pupils with much more careful attention. So we can see her pupil responses are intact. They dilate in darkness, they constrict in light. There's no abnormal pupillary responses, which you can see with dysautonomias. And then when we check her accommodation and have her track her finger towards her nose, the eyes converge and they constrict, which is normal. Eyes open, we're just churning you back and forth. Looking at your reflexes. You look pretty good. You're doing the job. You're going to do it with your eyes open now. Same thing. Just relax. Nice reflexes. Okay. And we're going to look at your eyes again. Keep your you have to move your arm with your mind.
Okay.
Keep staring at your thumb. Keep staring at your thumb. Staring at your thumb. And those are pretty good. So with vestibulocular reflexes, when you have someone with goggles on and they can't really visually fixate on a target, when you turn them in a chair back and forth, you can see as they go to the left, the eyes go to the right, and they have that bouncing nystagmus. And hers were normal, intact in both directions. And then I had to stare at her thumb, and this should cancel out the vestibulocular reflexes. And it does. So let's just know that her cerebellum is really healthy. These findings with, really highly functional, rapid movements without any kind of coordination issues, nice heel to shin function, normal stability, all rule out one of the things we were concerned with initially, which was that she may have some kind of cerebellar dysfunction or disease, which commonly accompanies those that have Hashimoto's or Graves, or even potential demyelination or injury to the brain, or things like ataxia. So all those main mechanisms seem to be ruled out with her findings so far. 2, 3, 4, 5, 6, 7, 8, 9, 10. Great. You feel okay?
Yeah.
2, 3, 4, 5, 6, 7, 8, 9, 10. I'm going to pinch you, and then I'm going to look at your pupil, see if it enlarges, dilates, okay?
Mm-hmm.
So here we go. Ooh, there we go. That's a response, okay. I'm going to clap next to your ear. Just going to see if your eyes jerk when we do that. Nope, that's very good. I'm going to compress your ear. And let go. Oops, steady. Okay. Cool. Compression. And let go. Okay, that's great. Good. Can you close these eyes? Keep going. And look straight ahead. And relax. Okay. So one of the things that everyone should have in their office should be some Frenzel goggles. And Frenzel goggles are not expensive, and you can get those for $200 or $300. And even if you don't have these infrared goggles that I'm using, you can have a patient wear these goggles and then do what's called a head shake test, or the flexion extension test. And the head shake test is basically having a patient shake their head for about 10 seconds left to right, and when they stop, you shouldn't see any movement of the eyes, any type of nystagmus. We mean the eyes bounce around, even if it's 2 or 3 beats of nystagmus, is an indication that there's something wrong with the vestibulocerebellar system. And then you can also check flexion and extension pathways, which are looking at the otoliths in combination with the semicircular canals rapidly back and forth, and see if there's any abnormal eye movements or jerkiness afterwards. And it's a really important test because there's so many people that do have cerebellar disease, cerebellar injury, since we have so many patients that are suffering from gluten sensitivity, and there's a potential for that gluten ataxia response to take place. And we also know that we see many patients with Hashimoto's have those TPO antibodies. Now with her, all of these tests are normal.